So I'd like to welcome you. Feel very blessed to have such a nice crowd here tonight, and fortunate. And thank you very much all for taking times out of your busy schedules and stuff to come tonight. That's much appreciated. My name is John Belidi. For a lot of you know me, and some of you are I'm getting to know you better. They're newer faces. So I'm one of the compounding pharmacists and one of the owners. My father, Gaspar Belidi, founded the pharmacy in 1964, so for over 60 years now, we have been serving this community. We're so excited to have Dr. Smith here to present on this important topics, cutting edge things to prescribing hormones. Especially, we're always very concerned about, we know the benefits, but there are a lot of potential downsides, especially with cancer and things like that, breast cancer in particular. So we're very privileged and to have an honor to have Dr. Smith here. And we're, of course, we're working with, where's Greg? There's my friend Greg. Greg is from ZRT Labs. We wouldn't be able to have had this presentation tonight without ZRT. We personally use them here to help test our patients, and they're a great group of people, extremely professional, responsive, and it's a pleasure to have you here, and we thank you very much, and you're all your folks at ZRT. Thank you. Again, so now, my dad founded the pharmacy in 1964. Now my son is here too, so we have it's 3 generations of in a family business. So we're very privileged again to be here to serving the public. And now I have James with Vince, so we have the next generation of people, also coming along here to help make sure we continue the care and continue the legacy. Great staff too. I have Sheldon, Rita, again, James, Deirdre, Pasquale, the pharmacist, plus my rest of the crew. Thank you guys for making this a great night already. I can tell it's going to be a great night. So this is our 7th seminar tonight on wellness, anti-aging, and precision medicine and personalized medicine. And it's very important, I think, and our focus is on collaboration, because I think that when we work with a practitioner and the pharmacist, and included the patient, of course, too, we're going to get our best outcomes. It's that triad or 3-pronged thing where you have, again, practitioner, patient, and pharmacist, just allowing us to work better together. My dad, Gaspar, really built this place on trust, patient advocacy, and again, personalized care. And these are values that I can promise you we continue to uphold. We take responsibility for our patients' well-being, ensure that they receive the best possible care. We share your mission as well of focusing on root causes and not just treating symptoms. We're also very committed to embracing innovative, research-backed, proactive approaches to patient health. And we feel it's very important to have good relationships with our practitioners and make sure that we're out there giving them evidence-based treatment recommendations, customizing compounded solutions for whatever the patient may need specifically, and conducting and holding events like tonight, which I think are important because ongoing education and collaboration are essential. I think we all have to stay sharp. We have to keep educated, and again, we're very honored to have Doctor here to help us make sure we're staying current. So that's why I think it's so important to have, like, for seminars like this, it's designed to provide stuff that you can, and information that you could take and put into your practice as soon as tomorrow. Also, please know that, and you had a tour here, and you should know that we prioritize safety and efficacy, and we make sure that the treatments align with best practices and regulatory standards. Tonight, I can promise you for sure that you're going to leave with some actionable insights for improved patient care. Also, for your convenience, we've included some copies of today's slides. You have that in front of you. There's also a notebook in your bag. There's also a short survey. If you don't mind filling that out, I'll remind you later. And so enough, you've heard me talk a lot. You didn't come all this way to hear me talk. So I'm going to now try to talk to you about Dr. Smith for a minute. Doctor, we're honored to have you here again now for the 3rd time. In addition, she has an extensive bio. We could take up the whole time probably telling you all the wonderful things she's done throughout her career. In addition to being an avid Tigers fan, Detroit Tigers, right? But
my second favorite is the Red Sox.
That's why we're kindred spirits. That's why we're kindred spirits, right? Go Sox. So her first 20 years of her career she spent in a level 1 trauma center in Detroit as an ER physician. So, I mean, tremendous amount of experience there. 29 years in personalized medicine, you know, so I think about that dedication, all the good you've done for patients. Internationally recognized author and speaker. This is one of the most interesting things, I think, that you guys should look this up. I think there's going to be some information about that, but I'd be happy to get you that if you want to know about it. She conducts, she's co-director of a personalized medicine certification program at Morsani College of Medicine in Florida. It's worth looking into, you know, to hone your clinical skills. Again, this is her, today you're getting a copy of her 14th book, How to Prevent Breast Cancer, included in your welcome packet. So without further ado, again, Doctor, we're privileged and honored. Thank you so much. Dr. Smith.
If anybody would like their copy signed afterwards, I'm happy to do that. Can you all hear me?
Yes.
Okay. So tonight we're going to look at how to prevent breast cancer and kind of really before and after. In other words, how do you prevent it and how do you prevent a reoccurrence? So the references are in the book, but they're really not in the book. They're online, and that way I can update the references all the time. Objective-wise, we're just going to look at modifiable versus non-modifiable risk factors for breast cancer. This is a subject that is near and dear to my heart because I do have breast cancer on both sides of my family. So it's something that I've always wanted to look farther into. It is the second most frequent type of cancer worldwide, and it's the most commonly occurring malignancy in women. Its incidence increases in developed countries, and 1 in 8 women get breast cancer. The reason I'm pointing that out is not just that's a startling number. When I was in medical school 50 years ago, it was 1 in 24 women got breast cancer. So this has changed in my practice time to a dramatically different number. Breast cancer incidence has continued to rise by 1% annually from 2012 to 2021. And most of the increase was in women with localized stage, but it is hormonally positive disease. There's been a steeper increase in breast cancer now in younger women. We used to always say, and the stats still say, it increases with age, but now we're seeing women that are 25 years old with breast cancer, which was uncommon probably before about 2017. There's non-modifiable and modifiable risk factors. Tonight, honestly, I don't have time to talk about the non-modifiable, or we would be here all night. So they're in the book. Let's concentrate on what we can do for our patients on Monday morning. So tonight we're going to look at the modifiable risk factors for breast cancer. The good news is you really can change these. So these we're going to look at, whether the patient breastfeeds or not, whether they've had children, frequent pregnancy, whether the first one is after the age of 30, diet, how much sugar they intake, high fructose corn syrup, alcohol consumption, cigarette smoking, exercise, toxins, particularly ones that are hormone disruptors, hypercholesterolemia, obesity, infection, vitamin D, hormonal balance. So it does matter if you give hormones. It does matter what kind of hormones you give. It does matter the dose of the hormones, and it does matter how you measure them. We're going to look at all of that. Whether the patient's been on oral contraceptives or not, methylation is important. If I could just choose one, hands down, it would be inflammation. A little bit of inflammation heals, too much causes disease. And almost every disease after the age of 42 is inflammatory in nature, particularly breast cancer. And then, of course, gut health, because 70% of the immune system is in the GI tract. It does matter if you breastfeed your children or not. That is a personal decision. There's no one on earth that has all of these risk factors perfect. You just do the best that you can. So the risk factor of breast cancer is reduced by 4.3% for every 12 months of breastfeeding. This is in addition to the 7% decrease in risk observed for each and every birth. So if you've had 5 kids like I have, then you can see how the risk factor goes down. Breastfeeding does reduce the risk also of triple-negative breast cancer, so not just hormonally related, and also whether people carry the BRCA gene or not, it still decreases the risk factor. So in contrast to the protective effects of childbearing, the protection conferred by breastfeeding is not limited to estrogen receptor positive breast cancer. So basically, this meta-analysis suggested that longer duration of breastfeeding was inversely related to the risk of breast cancer. So you need to really go at least 6 months to get this protective effect. Some great studies. Here, the first one, Victoria and colleagues looked at the existing global breastfeeding rates, prevent almost 20,000 annual deaths. It's a pretty startling number. How about whether you choose to have children or not? Again, that's a personal decision. My last daughter, I have 5 of them, has decided not to have any children, even though she knows that our family has a very strong history of breast cancer. Numerous studies have confirmed a strict relationship between the exposure of endogenous hormone estrogen and progesterone and whether there's excessive amounts of them related to breast cancer. So the occurrence of pregnancy, breastfeeding, first menstruation, menopause, all of those things do confer different risk in the patient. And in the last couple of decades, large case-controlled studies have shown for the protective effects for estrogen receptor positive and progesterone receptor positive breast cancer if you do choose to have children. First pregnancy after the age of 60 is a risk factor. And I did consider that when I had children. I had my first child at 25, but it was a conscious decision because I was an intern when I got pregnant. But I didn't want to wait till longer because, I mean, I have a grandmother I never met. I have a whole host of people on both sides of my family, and many of them have died of the disease. Some survived, but all the time, more family members come up with it. So I did consider when I should have my first kid. So the first full-term pregnancy at any age, especially in the early 20s, along with subsequently increased number of births, reduces the risk. So besides the pregnancy itself, protective effects against potential cancer, basically you have to go to at least the 33rd, 34th week of pregnancy to get that protective effect. Diet. The Mediterranean diet is just key. So tonight we're dining upon some Mediterranean food. So we're all decreasing our risk of breast cancer. Gentlemen, it used to be 1% of breast cancer was in men. It's now 3%. And also men, everything that I'm saying about breast cancer, almost all of this, methylation, all these things are the same risk factors for men and prostate cancer because originally in utero it comes from the same tissue. So there's all these studies. I'm not going to belabor them. I'm just going to show you Mediterranean diet, 25% decreased risk, Mediterranean diet, you get the point. So when people say, should I fast? What should I eat? My response is always the same. It doesn't matter what disease we're talking about. Eat Mediterranean, it's anti-inflammatory. So great way to go. This one is my personal nemesis. I like sugar. I truly do. It is probably the most addicting substance on earth, probably more than cocaine. It truly is. Numerous studies, though, have shown that almost everybody gets cancer cells, probably 6 or 7 times in their lifetime. But if you're healthy, you kill the cells. There's 2 things that feed the cells beside toxins. sugar, and stress. So great studies on sugar intake. A lot of this has to do with the 12 lock system. This study found a higher total sugar intake of sucrose, sugar, and fructose. All of these, if people drank fruit juice all the time, they have an increased risk in breast cancer because it is liquid sugar. So I drank orange juice the other day because I was near a whole bunch of people that had had COVID. So I just drank a bunch of vitamin C in my orange juice. It's probably the first glass of orange juice I'd had in 3 or 4 years because there was an increased risk. So it's not back to the old days where, hi, everybody needs to drink a glass of juice a day. That is probably not true. High fructose corn syrup is one of the worst things ever developed on earth. I don't say that just because I hail from Michigan. We are the largest beet producers of sugar beets in all of North America. So a lot of our economy is based on sugar beets. I say that because that's where the science is. To be really simple about it, and the way I explain it to my patients is when it comes to fructose, it is the only carrier in the world that really doesn't have to be there. You need a carrier to take sugar into the cell. That carrier is called insulin. The only sugar that doesn't need a carrier is high fructose corn syrup. So it goes immediately into the cell all by itself. It doesn't need any other help. And that is why it is such an issue for many, 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 many reasons. The preceding decades, the average person in the US has shifted from eating 16 to 20 grams of fructose to 60 to 150 grams every single day. Fructose has the highest sweetness among all natural sugars. It is more easily metabolized than glucose, and it can be used by breast cancer cells. And the studies do show that a high fructose diet accelerates the process of breast cancer. So it accelerates whether you get it. It also accelerates whether you get a reoccurrence or not. Because part of our job is to help people also not get a reoccurrence. Epidemiological studies play this out when it comes to tumor genesis and the tumor progression as well. It's been shown to be related to an increased risk in triple-negative breast cancer also. So hormonally related breast cancer and triple-negative breast cancer. Large quantities of dietary fructose are associated with specific metabolic changes in the mammary glands. So this is now well described in the medical literature. This is always a hard subject. But what is the actual science when it comes to alcohol? I am drinking a sparkling water. Why am I drinking a sparkling water? Who knows?
You're driving home.
If you go on the American Cancer Society website, it says the following. If you have a family history of breast cancer on both sides of your family, you should never drink alcohol. So I don't. Because it's a risk factor I can fix. For all the rest of you, if you don't have my family history, then moderation is the key to health. Estrogen is increased, however, in women when you drink alcohol. So the studies have shown when you go past 1 drink, you increase your risk of breast cancer 3 to 8-fold. So again, it is a moderation thing when it comes because, again, it's honestly just liquid sugar. So drinking enough, even small amounts, is linked with an increased risk in breast cancer. I would be a very poor physician if I did not say that. And there's your reference to that. Alcohol consumption can raise the level of estrogen, and this meta-analysis based on 53 epidemiological studies, showed that 35 to 44 grams of alcohol per day increases the risk by 32%. And there are several studies. This one shows this one shows it, this one shows it even in premenopausal women. Here's another one showing both of these that it drives up estrogen. Here, that's associated with an increased risk in getting the disease. But if you also get the disease, there's an increase in poor prognosis if you get the disease process. Nobody is going to do everything. All 16 plus of these things, honestly, nobody's going to do them all. Do the best you can. Teach your patients what they are, because some are easier than others. It's hard for me to believe I have to mention cigarette smoking, but 1 billion people still smoke cigarettes. Cigarettes, the illnesses cost greater than $300 billion a year in the United States all by itself. The overall mortality from any cause was increased by 60% for people who are heavy smokers. I always tell my patients, you're probably not going to get lung cancer from smoking. I've been practicing 47 years. Most of my patients who smoke never get lung cancer, but almost all of them get cognitive decline. Many of them get macular degeneration. Most of them do get heart disease or have a stroke, and there is an increased risk in breast and prostate cancer. So the European Prospective Investigational Study showed this. This trial found breast cancer to be associated with the duration, intensity, cumulative exposure, and latency of smoking. Findings here are consistent with the prior observation. This is from 2021. And here, prospective study from 2017 found that smoking-related exposures were more consistently and strongly associated with ER-positive than ER-negative breast cancer. So studies showed that smoking 40 or more cigarettes per day had the strongest association risk, and the weight of the evidence suggests potentially causative role. And here, 9 cohort studies found an increased risk with the duration of smoking of 15% to 40%. And the association with smoking varied by alcohol consumption as well. So if the person both smoked and drank, the risk factor was higher. Several studies have investigated patients who've already developed breast cancer. If the patients already had this disease, if they smoke, then there's even more of a risk of 54%. Cigarette smoking did not alter the underlying biology of the breast tumors or the breast cancer-specific survival. The overall survival was worse in smokers, so smoking cessation from 2022, even if they've already had breast cancer, helps with their longevity. Exercise. I used to hate exercise. I really did. I just didn't get the high out of it. If you've heard me speak before, you've heard me say that. So I started exercising to maintain memory. But after researching all this for a year and a half to write this book, I really do exercise. I just don't miss, because it significantly decreases a woman's risk of getting breast cancer. And in fact, women who get regular exercise have a 10 to 20% lower risk than women who are inactive. Physical activity during adulthood is linked to lower risk, and being active also lowers blood estrogen levels to a more physiological dose. For most women, moderate to intense activity like heavy housework, brisk walking, my personal favorite, dancing, are really considered exercise. And there's several studies showing that. So can she exercise her way into it by dancing? She can. Great studies on ballroom dancing, and even better ones on square dancing. Because if you square dance, you have to listen to the calls. There's actually a study showing that it helps you maintain memory. So just kind of a lot of little interesting things in the medical literature when you go through all of it. And of course, exercise does help with weight control, and as we're about to look at, obesity is a risk factor. Exercise also boosts the immune system because people get immunosenescence with age. The immune system becomes compromised unless, what happens? Unless she is on bioidentical hormones at the right dose. Hormone replacement therapy, there are many reasons to take hormones. Yes, it's about symptoms. Yes, it's about memory. Yes, it's about prevention of heart disease. Yes, it's about how your skin looks. Yes, it's about bone structure. But it's also about the immune system. So my patients honestly didn't have a hard time with COVID because they were all hormonally balanced, whatever that meant to them. But please only give the hormones that the patient needs. And we're going to delve into this a little bit more. So this study found lifestyle factor most strongly and consistently associated with both breast cancer incidence and reoccurrence. If you could only choose one, was physical activity. So how many of you ask your patients if they exercise? Raise your hand. How many of you actually sit down and talk to them about what kind of exercising do you do? Excellent. So all of you discuss with them if they want to maintain bone structure, that swimming is a great exercise, but it doesn't maintain bone, right? Because the exercise has to be on the ground in order to maintain bone structure. So if she swims 3 days a week, she may have cardiovascular health, but she probably will still develop bone loss because she wasn't doing it on the ground. The impact of exercise consistently studied distinct phases of breast cancer. They looked at it in the whole continuum. It's very important for exercise because it helps psychologically as well. This finding from 2021 suggests that even moderate physical activity was associated with a 60% lower risk of death among breast cancer survivors. So even if she's already had the disease, please have her develop an exercise program. I usually don't use weights when I exercise. I've just never really kind of been into the weight thing. Recently, and I'll be 71 in July, I realized that some of this was getting a little bit saggy. And so there's only so much that hormones can do for that, right? Because we know testosterone helps with muscle mass, and so does estrogen. So my husband, he was going to the store and buying some things to exercise with, and I had him get me some 2-pound weights. The new joy of my life is my Labradoodle. She's just so cute. So when I come around and sign your book, if you want to see Banjo, my Labradoodle, a picture, she's adorable. I put those weights on my bedside. Banjo thought they were for her. She jumped. All of a sudden, we were downstairs in front of the TV set. We had just finished reading a book. We thought we'd watch a ball game. All of a sudden, there was this big crash, and it was Banjo. Banjo had knocked down those little weights. She thought they were for her, and she had dragged them into the living room and was gnawing on them. But having laughter decreases your risk of heart disease. It decreases your risk of breast cancer and a reoccurrence. The American Cancer Society recommends a specific amount of exercise. So they've actually delineated this out quite well. In patients that have had breast cancer, some studies show being active after breast cancer was linked to a lower reoccurrence. An exercise prescription tailored for that person always does better. So I have my patients actually go to physical therapy, and they get I give them a prescription for exercise, and the physical therapist helps them learn an exercise program. Before we look at toxins, what questions do you all have? How many of you really, before tonight, had this perspective on breast cancer? So some of you did. How many of you never thought that you really should look at a different reason as to why? So at least you all thought about it, right? Except for a couple people. Toxins. Endocrine disrupting chemicals are a problem. As you all know, there are substances in the environment that affect the actions of hormones in the body. There's a number of different mechanisms why that happens. So probably one of the biggest ones are bisphenols and also looking at phthalates. There's 20 articles that met the inclusion-exclusion criterion in this study looking at parabens and benzophenones. BPA is a toxic endocrine disrupting chemical. I quit measuring BPAs 5 years ago. My MPH is in toxicology. So do I do toxic metals all the time and chelate? I do. Because increase in heart disease, increase in cognitive decline, et cetera. But you know what? We could never get rid of gadolinium. We couldn't get rid of aluminum. We couldn't get rid of BPAs. So I quit measuring them because the only thing we had to offer was a sauna. And I mean, that one only got rid of 5 to 7%. So why scare the patient, right? Hi, you have something I can't help you with. So I quit looking at them. But they are an endocrine disruptor. So they're everywhere in the body, and they do increase her risk of breast cancer. People are exposed all over the place, from food to drinking water. It's been shown to induce tumor aggressiveness and a poor prognosis. Inhalation occurs as well from vinyl flooring, carpet bagging, and consumer products like fragrances, dryer sheets, air fresheners, sunscreens. There's no carpeting in my house. There's a reason for that. I don't use dryer sheets. If my clothes cling to me, oh well. I don't like air fresheners. When I came here to speak, my staff actually called ahead to the hotel and said, please do not put any air freshener, otherwise known as Febreze, into Dr. Smith's room because she's allergic to it. That's what my staff has been trained to say because it is a toxin. I have Mediterranean skin, so I usually don't wear sunscreen. Some of you do need to wear it because you don't want to get cancer. But if you have a more Mediterranean skin, as long as you're not burning yourself, you get some vitamin D. Great study. 25% of the major toxins that a woman gets in her body is from her hair, shampoo, conditioner, face creams, eye creams, neck creams. Isn't that amazing? A lot of them are really, really toxins. So honestly, I only use natural products for all of the above because synthetic ones are an issue. So what does the literature actually say? Exposure through dermal contact occurs with the use of phthalate-containing personal care products like sunscreens, lotions, and cosmetics. BPAs are released. Here they are in toys, tableware, medical devices, polycarbonate bottles. Think about IV tubing. It is a plastic. Can you do without plastic? Probably not. But we can limit our exposures. So you notice tonight that you see the sparkling water is in glass. It is not in plastic, because it's just a few things that you can do. One of the worst places to get BPAs is breast implants. Breast implants. And I will guarantee you, because this has happened to me, that the surgeon will say, there's nothing wrong with breast implants. So number one, there was silicone. There's silicone. Obviously, that's bad. Oh, we developed saline ones. What holds the saline together is silicone. So it is still there. So there's an increased risk in autoimmune diseases we've now known forever. Forever. So I have one patient who is a doctor. She's also my friend. And I work with her, and she lost 100 pounds. And of course, the breast sagged, so she got implants. She didn't even tell me. She got them, and I had done her toxin test. And the BPAs were crazy. I said, where do you think they're coming from? Do you think it's my breast implants? I go, yes, it's your breast implants. So she went home. She goes, I can't believe this. She went to her surgeon. He said, it's not breast implants. There's nothing wrong with these. So she went and she got rid of all plastic everywhere in the world. All of it was totally gone. There was nothing else plastic in her life. She went through her office, her home, everything. Her test was better when she repeated it, but only 20% better because it was the breast implants. She is not going to have them out. That's a personal decision, and I really support her in that because you can't fix all of them, and it's part of her self-esteem. Better to have breast implants than to have depression. She doesn't have an autoimmune process. But the good news is now we can offer specialized TPE, therapeutic plasma exchange, not just TPE. TPE, how many of you are familiar with it? Oh, you guys are not my age. Okay. If you were an ER doctor and you're my age, you use TPE in the ER. I existed before Narcan. Okay, so when I was a young doctor, there wasn't Narcan. So when a drug overdose came in, we put people on a TPE machine, and that is how we got rid of it. Yes, it's a pseudo-dialysis. You take it out, and at that time, we cleanse the plasma and we put it back in. So now there's new methods of doing TPE. They take it out, put albumin back in. Part of a clinical trial where we're actually giving nutrients and DMSA and LDN and all of those things, of course, compounded. The DMSA is compounded, the LDN is compounded, and we actually can get rid of BPAs in every patient. We have 400, 92 to 100%. We have gotten rid of 100% of gadolinium. We have gotten rid of 100% of aluminum, provided they're not still going back and cooking in an aluminum pan. So my friend that won't get the breast implants out, she's having her TPE, which is usually 5 to 8 courses, 3 to 5, depending on how bad it is. Now she's just going to have it every year because she's going to keep the breast implants in. The point being, endocrine disruptors are really huge when it comes to breast cancer. But they're even worse if you have not worked with the patient so that they're hormonally balanced. Because if she's already estrogen dominant and you're not giving her something to also get rid of the endocrine disruptors, you can see how all of this happens. You can see how all of it happens. Here it occurs through water contamination and air contamination. BPA is found in the urine of 93% of people in the United States. Here's some other great studies, how much is being produced every year. It is really hard on the nervous system as well. It increases the risk of heart disease, and it literally binds to both the alpha and beta estrogen receptors in the body. It also affects GPER, that is the third estrogen receptor in the body. It can stimulate some cellular responses at very low concentrations. In some cases, BPA is equivalent in potency to estradiol. Think about that for a second. It's equal to estradiol itself just by what the person is exposed to every day. So this study looked at increased risk in breast, colorectal, ovarian, and prostate cancer. And then the other study, there's an increased risk in thyroid cancer from 2022. So studies shown that low-dose BPA can promote DNA instability. It disturbs DNA, it damages it, it changes the signaling pathways in the body. So all of these studies show the same thing, and you actually get hyperplasia of the breast tissue. I have people all the time asking me, well, I have dense breast. How do I get rid of dense breast? Part of that density and hyperplasia that occurs is coming from BPAs, phthalates, et cetera. And that's now been shown in all of these studies. With phthalates, the term refers to a group of chemicals in plasticizers, substances added to plastics to make it durable, to make it more flexible. So they are part of the packaging material that occurs there is an association with breast cancer. Both of these studies were very, very clear that phthalates are a major risk factor. Parabens are synthetic things that are in preservatives. They're in beer, sauces, jams, soft drinks, personal care cosmetics. They contain parabens as well, and parabens at an increased rate increase the risk of breast cancer. How about pesticides? Links between breast cancer and environmental pesticides from farming, absolutely positively there. TPE gets rid of most pesticides as well, at least at a 75%. So we're looking at it for MS and Parkinson's and all those neurological disorders, including cognitive decline. Studies reported the higher levels of DDT or DDE among women with breast cancer than controls does occur. And here, U.S. women who reside closely to incinerator plants for long duration from 2020, that's dioxin, they have an increased risk in breast cancer. Other drugs, they might be a risk factor for breast cancer. Some antibiotics, some antidepressants. Statin drugs absolutely are a risk factor for breast cancer. So are some antihypertensive drugs like calcium channel blockers, angiotensin II converting enzyme inhibitors, and nonsteroidals. Okay, how many people knew that before tonight? The only one I knew before I researched this book was statins, because that's been known for a long time. Part of the reason is statins drive up blood sugar, which is a risk factor. Radiation exposure increases the risk of breast cancer, even radiation that is being used to do medical tests. Would that mean mammogram? It would. So do I send every single patient for a mammogram every year? I do not. Do I believe in thermograms? I do. If thermograms are not normal, then they can go on to mammography. The ultimate study is an MRI. Then the question is with or without contrast. Because until now, with TPE, you can get rid of the gadolinium, but before then, you could not. So these are actually the stats from our study that we're publishing. It's coming out in a medical journal in 2 months. Microplastics we got rid of by 90%, heavy metals decreased by 80%, aluminum 100%, BPAs and phthalates 97%, and the rest of the environmental toxins up to 95%. So, also it does matter if you just like help people. Everybody's not going to have TPE. So what can you do on Monday morning? You can help them buy the right kind of air filter for their house, the right kind of purification system for their water, using non-toxic skincare products, switching to natural cleaning products, and using essential oils for fragrances instead of perfumes. I am so funny when I'm in a mall. The little people standing at the store that are trying to sell you something. Oh, come try our little. You don't want me to try it. I probably will have an allergic reaction. Oh, it's like, no, 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 no. There are some people who are chemically sensitive. I am to some things. What I can tell you is that some of that chemical sensitivity is related to toxins. When you get it removed, it is very beneficial. How about high cholesterol? Yes, it's a risk factor for heart disease, but it's also a risk factor for getting breast cancer. For ER-positive breast cancer, and that is not a typo, you notice the date is 1990. Cholesterol and its metabolite, 27-hydroxycholesterol, has been shown to possess estrogenic activities. It is a risk factor for ER-positive breast cancer, also associated with a decreased response to endocrine therapies. So chemotherapy does not work as well, particularly if it's an endocrine variety, if the patient's cholesterol is high. That doesn't mean getting it too low, okay? So let's stop for a second and talk about one hormone, pregnenolone. Pregnenolone is the hormone of memory. It is all about the immune system as well, but you do have to have a total cholesterol of 140 to make pregnenolone to make the other hormones. So we don't want it too low either. We want cholesterol to be not inflamed and to be 140 to 180. The most important thing is inflammation. Statin drugs lower cholesterol by decreasing inflammation. That's how they help prevent heart disease, not the cholesterol lowering effects itself. And there's your reference on that.
Excuse me.
Mm-hmm.
I'm sorry if I can interrupt.
No, that's
When
fine.
you're talking about a high cholesterol, I think you should take into consideration the breakdown, because if someone has a very good level of good cholesterol, you don't have to worry about inflammation, because that's already improving your immune system and getting rid of lots of toxins. So I think.
Did everybody hear her? Okay. So this is not a seminar on heart disease.
No, I
If
understand.
it
I'm
were,
not talking about heart disease, I'm talking about increasing inflammation, like you were explaining, and then with the cascade increasing chances of getting breast cancer.
so what's the number one risk factor for heart disease?
Shouldn't you consider in a hypercholesterolemia to prevent breast cancer also the type of cholesterol that you have? If you have a good high HDL, I don't think it's at the same level as someone who has very low HDL. I don't think you should go by the number.
I would disagree with that, because
Okay.
the number one risk factor for heart disease, particularly for a woman, is whether lipoprotein A is elevated
Okay,
or not.
that's exactly. So
Okay.
we're talking about breakdown.
Yeah, so,
We're talking
but
about breakdown.
I hadn't gotten there yet.
Oh, I'm sorry. Okay.
That's okay, no issue. Hadn't gotten there yet, okay? So you're right, it's not just about that. My point being, it's about inflammation,
Right.
okay? So another study showed the same thing, and 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 another study showed the same thing, even related with vitamin D supplementation. So for the naysayers out there, okay, it does matter. The cholesterol should not be 220, but it shouldn't be total 110 either. And it does, as you pointed out, does matter what the HDL and all these other things are, like homocysteine, C-reactive protein, ferritin, fibrinogen, interleukin-6. We could go on and on. Yes?
So if the statins increase breast cancer, but also high cholesterol, what is your recommendation for lowering cholesterol that's not a statin?
So my recommendation for lowering cholesterol is a myriad of things. If the patient's had an acute MI, it's malpractice not to give a statin drug. However, it doesn't mean you have to give Lipitor 80 milligrams. I might give 10 milligrams Monday, Wednesday, and Friday. I'm still giving a statin drug because it does raise blood sugar. And it really does not work as well in women. That's what the studies show. So the number one thing I do to lower cholesterol itself and inflammation is bioidentical hormones, because estrogen lowers cholesterol and it decreases inflammation if it's given correctly. Number two is soluble fiber. Number three is exercise. Number four is decreasing stress. And then we can go on to berberine and plant sterols, and we can go on to bergamot, and we can go on to polycosanol. There are a myriad of things, and some people need 3 or 4 or 5 things. Garlic actually has great studies that it helps lower cholesterol. There's a whole host of things that do. So I use a statin drug if they've had an acute MI, but otherwise I don't, if I can get it at least to a reasonable range. The point here being that it does matter when it is related to breast cancer, but my number one thing for lowering cholesterol is bioidentical hormones properly given. Because when do you see this? When do you see cholesterol, blood sugar, and blood pressure start climbing? Unless it's related to, your family history, when she starts losing her hormones. She didn't wake up at the age of 25 and go, "Hi, I'm hypertensive," provided she had normal kidney function, etc. Her cholesterol was probably low. I mean, let's take me. My cholesterol was 142, it's now 182, even with hormones. I mean, my blood pressure was 90/50 until I became perimenopausal. It started creeping up even with hormones. It's still not 90/50. So those things do change along with age and all those other factors. But yes, there are many things that you can do to try and help that, okay? Obesity When I was in elementary school, we had 640 children. There was one obese child, and he happened to go to the same high school that I did, and he passed away as a senior. He had a PE and died. We didn't have any other obese children. In my entire school, we had one kid with autism, and we had 2 kids with ADD in the whole school. What has happened? What has happened in all this? Exercise does help with weight control, but obesity is an inflammatory state. So obesity increases the patient's risk of heart disease. This is a male story, but it's a true story, so I want to tell it. A couple weeks ago, I was in Publix, which is a grocery store in Florida. We have Kroger's in Michigan. You all have yours. But in the supermarket, and I just couldn't help looking at the guy in front of me. And you know, I try not to judge people. I really do. I try and put it like a zipper on my mouth. I try and do all those things. And I just couldn't help myself. He was so obese. All I could think of is, gosh, if I saw you in the ER, I would have to know the medicine to give you, how much. I'd have to take you to the loading dock because we have no other way of measuring you. 400 to 450 pounds. He couldn't even like wear his pants. They were falling down. He kept doing this. It was just unsightly, needless to say. And then I looked at what he was buying. The poor man had more in his cart than I would eat in 3 weeks. But what was in there? He didn't know that there was such a thing as a fruit. There were no vegetables. Here was the high fructose corn syrup, and here was the Cheerios, and we went all the way down the line, but then he topped it off. He thought he had it right. There was that Diet Coke. Isn't that your patient? It is your patient, right? It is your patient. So it does matter what they weigh when it comes to all of this. The average woman gains 20 pounds at menopause. If you do not help her be hormonally balanced, she will probably gain that 20 pounds and never lose it, because estrogen does what? One of its functions is insulin regulation. Estrogen has 400 functions in the body. It's taste, touch, smell, hearing, skin tone. It lowers cholesterol, blood sugar, blood pressure. It is her memory, and so much more. But a big thing is regulation of insulin. But people somehow forget that. Estrogen is not evil. It's only evil if you give synthetic and you don't give a physiological dose. So look at these studies on adiposity. It is associated with a greater probability of breast cancer from Cancers 2020. Here, females above 50 with greater body mass are at greater risk of developing any kind of cancer from 2019. Another one with BMIs associated with metastases, greater size of the tumor. Here, it enhances the inflammatory state. This is from JAMA Oncology. Postmenopausal women tend to present poor clinical outcomes despite proper BMI values, but normally due to excessive fat volume. So then you see what? You see on TV Sonabella and all these other things that we can help you get rid of this fat. We can just suck it out. Everybody wants a quick fix, right? Because that's the kind of society that we have. A dietary fat has been associated, if it's the poor fat, to triple negative breast cancer as well. And the overconsumption of fructose, again, leads to obesity, which leads to an increase in breast cancer. Same thing in this study. Meta-analysis, 10 studies, 5-unit increase in BMI associated with a 33% greater risk of developing ER-positive, PR-positive tumors. So weight loss is for many things. One of them is to prevent the risk factor. Great study here looking at an increase in breast cancer, ovarian, and endometrial cancers, all related to obesity. And the WHI clinical trials showed the same thing of Now, 67,000 people. This data suggests that adult weight gain and central obesity increase the risk of premenopausal breast cancer as well. Here, weight loss does exert a protective effect. It is never too late to help her lose that weight. And this article concludes that obesity contributes to the development and poor prognosis of breast cancer. How about infections? Certainly since COVID, we have talked more and more about infections. Are infections related to breast cancer? For many years, breast cancer has been associated to some kind of infection, viral, bacterial, fungal infections. So it has been associated in some articles with different kinds, like the human papillovirus, herpes virus, MMTVs. Here, 30 studies showing 17 countries, 4 continents, all showed the same thing. Increased risk with HPV of breast cancer. Some studies said there was no increase, and some studies said there was up to 86%. So there probably is a viral component for some patients. Here, BLV, a retrovirus, showed that there was a significant increased risk in breast cancer. EB viruses, there's an increased risk. This one, it's hard to know what to say because 99% of people have had Epstein-Barr. Another one on Epstein-Barr, another one on Epstein-Barr. This study from 2020 showed that COVID-19 induces the production of factors previously implicated in the reawakening of dormant breast cancer cells. Oh, she had breast cancer cells already there. And because of what happened with COVID, because it is an inflammatory state, it woke up those cells. Bacterial infections have also been shown to have an increased risk. A lot of this is coming from the GI tract. And fungal infections have been found in different body sites. I'm currently having TPE because my toxin was fungus. On the toxin test, which is over 100 different things, it looks at all of this stuff, including mycotoxins. Most of my other things were fine because I had chelated out my lead and mercury years ago and really wasn't re-exposed. I don't eat swordfish and all those things. But from staying in hotels and hospitals, hospitals are full of fungus. A lot of them have had water damage. So cancer of the breast is associated with fungal infections in a number of studies and a number of different fungi. So I listed some of them here for you. Vitamin D. It's really not a vitamin, it's a hormone. And studies have shown that breast cancer and vitamin D, if you don't have enough, it increases the risk. Another study showing this. In this trial, 100 women confirmed breast cancer versus matched controls, significant association whether they had optimal vitamin D levels or not. And for breast cancer, Grant's done the study, then Garland, then Vasquez. So that's 40 years of studies. So the most recent by Alex Vasquez, who is still practicing in Portugal, basically has shown that perfect vitamin D to prevent and treat breast cancer is 55 to 80. 55 to 80. So 45 is not good enough. Obviously you don't want to be toxic, so you have to measure 55 to 80. There are some people you cannot get that high because calcium goes up. Obviously people with hyperparathyroidism, right? People with granulomatous diseases like Crohn's, sarcoid, etc. And some people, when the cancer is really active, if you give a lot of vitamin D, then calcium climbs. So you have to be really careful to look at calcium and ionized calcium at the same time. This review suggests a protective relationship with vitamin D. Here, the prevalence of vitamin D deficiency in breast cancer, depending on the study, was between 23% and 95.6% of women who got breast cancer. And here, a total of 135 incident breast cancer cases were looked at with matched controls. Again, no breast cancer. Sorry. lower risk of breast cancer if vitamin D was higher. If the vitamin D was too low, an increased risk, particularly in African American women. 25-hydroxy vitamin D concentration significantly inversely associated with postmenopausal breast cancer in this study. Same thing here, same thing here, same thing here. You're getting the point, right? Measure vitamin D. It is possible that vitamin D plays a role in controlling normal breast cell growth and the capacity to stop the growth of that breast cancer cell may be regulated by vitamin D. High expression of COX-2 in the breast cells have been related to whether the patient has enough vitamin D or not. And of course, you knew I would get to hormones. I'm not sure I could ever give a talk without talking about hormones. I love to talk about them, but here it is key. So let's start out with a quiz. For those of you who've heard me speak before, you cannot answer. How much estradiol does a woman make when she's 25, at the peak of health, preluteally, which is when she makes the most during the month? How much does she actually make? Who knows? That is the problem. We are now almost to 38 years of asking this question on 4 continents and no one's been able to tell me. How are you prescribing it if you don't know how much to give? You don't know how much she makes. She makes 350 micrograms. That means nobody needs Bias cream of 7 milligrams or 10 milligrams or some of the crazy things that I see. Estrogen dominance leads to breast cancer. People can be estrogen dominant from the environmental toxins. PMS, PCOS, perimenopause, menopause, endometriosis, fibroids, they're all estrogen dominant states. It's all about hormonal balance in the body. But in order to balance those hormones, you have to know how much she makes. How much DHEA does she make? Does it stay stable during the month? Who knows? DHEA stays stable. It doesn't change with the cycle, and it's 7 milligrams is what she makes.
Is that per day?
That is per day, okay? So let's talk about measuring hormones, because that will make it easier to understand hormonal balance. How many of you measure hormones by blood? Be honest. How many of you measure by saliva? How many of you measure by urine? Okay, now let's go to the science. It's talking to me. Probably not a good thing, huh? So let's talk about that while we're fixing all of this. And now we have, there we go.
Yeah, you're ready.
Okay, thank you. No worries. How many of you agree that estrogen has to be on the skin? Let's start there. How many think that? Raise your hand. It does, okay? There are many studies, and I don't have time tonight to go through them all, but there's at least 40 studies showing that estrogen has to be on the skin and should never be given orally. If you give it orally, it causes inflammation. If you put it on the skin, it decreases inflammation. If you give it orally, it drives up blood pressure. If you put it on the skin, it decreases blood pressure. If you give it orally, it lowers growth hormone, the hormone that keeps you young. If you give it orally, it can cause cholecystitis. We can go on and on. But the studies are definitive. There's at least 40 showing that it has to be on the skin. That is from JAMA, Journal of OBGYN. That is from very traditional journals, not the Journal of Alternative Therapies. And that's the reason why you see the estradiol patch there. Okay? It really, the science is not to give it orally. How about oral contraceptives? Before you ask, for those of you who want the reference, I'm going to give you my email at the end. There's a study showing that if she has ever taken oral contraceptives, or if she's ever had IUD with hormones, all comers, doesn't matter your family history, she has a 20 to 30% risk in getting breast cancer, all comers. The slide is probably in here. Are we telling our patients they're at an increased risk? It doesn't mean don't give them. Are we giving them the actual risk factors? Part of that is related to progestin, part of it is related that the estrogen is oral. When it comes to looking at the hormones on the skin, testosterone should be on the skin as well. If you put the hormones on the skin, they do not show up in the blood, period. David Stava did that study in 2016. There's an Israeli study, and we will be publishing ours shortly. We took men and women. We took every hormone there was. We took a myriad of ages. It didn't matter the hormone, the sex, or anything else. If you put the hormone on the skin, it does not show in the blood. Pardon?
I have to disagree.
You can't disagree because
Yes,
that's a
I do.
science.
Well,
There's other
I talk about experience. I have been prescribing bioidentical hormones for probably 30 years.
Okay.
I am a user for over 20 years
Mhm.
myself. All my patients, I take a blood test. I do at least once a year before and after until they are in balance. And I can tell you when they're not using the hormones or they're using the wrong dose, it shows on the blood test.
And so how much estrogen are you giving and what form are you giving it in?
Always in a cream.
Okay.
Okay, I never prescribe unless I have just 2 or 3 patients that I want to take pills and they're aware that it's not a good idea, but that's their choice.
Okay.
The vast majority are taking, creams, and there is a way to use the cream because the cream needs to be applied here.
That is incorrect.
Okay.
The Journal of OBGYN says it has to be an area of fat cells. You are very beautiful from the viewpoint. You are a beautiful woman, plus you are not heavy. So you don't have a lot of fat cells. So you're going to have a harder time finding where to put that estrogen on your body.
Okay.
But it has to be applied to an area where there is fat cells.
I
So
disagree.
never put it here.
I disagree, and I'll tell you why. Because
You can't disagree with
Okay.
science.
Yes, exactly. No,
Okay.
I'm talking about science. I was at a conference
We'll make this
in
really
Paris
simple, because
with,
I'm not going to drive up my cortisol
Okay.
by having a discussion with you that's intense.
I'm sorry,
So
but
I
this
will
is-
provide you with references,
All right.
and
sorry.
you provide me with references, and then we'll have a discussion.
Okay.
How does that sound?
Okay, sounds good.
Okay? But I'm teaching you not only what's in science, but I direct the only course in the entire world that validates bioidentical hormones in a medical school. So everything that is coming out of my mouth, I represent the Morsani College of Medicine at the University of South Florida. It has all been validated. It's not gossip, because you know what? That's what we do now. We gossip. We repeat things that are not true, or anecdotal information that you might find in your own practice, but that is not what it actually shows in the medical trials. So I'm going to do to you all exactly what I do to any doctor that says something to me. Show me the trial. Because everything that's coming out of my mouth, I have a trial for. So my book on bioidentical hormones, which is my 3rd, and I have written almost the entire world's literature on the subject, and I actually am the only OBGYN, non-OBGYN, that writes for menopause. So in looking at this whole thing in 47 years, please make sure you do not do serum testing, because you will overdose the patient 100% of the time. And are you going to give her an increased risk in breast cancer? If you do, absolutely, positively, without a doubt, it is a risk factor. So how long does it actually take the hormones to get in? Has anybody really studied this? Yes, actually someone studied testosterone, because we had this ongoing discussion. So someone actually took and did a clinical trial. And what they did is they put testosterone on the skin. All these hormones are so lipophilic. You know how long it took For testosterone to get into the actual body, who knows? It's really fascinating. 12 minutes. You can stand there with a syringe and you're not going to find it. So how would you use serum testing? Because it only took 12 minutes to get into the tissues itself. That's what I mean by misnomers. We're all here tonight to learn, as am I, from the actual science. You also have to measure cortisol by saliva. That is per the medical board in this state and every province and most industrialized countries in the world. So every lab in the world now does cortisol by saliva. You can go to Quest, you can go to LabCorp, you can go to any lab in the world and get cortisol by saliva because the 6 clinical trials say that that is the standard of care. If you're not doing saliva testing for cortisol, that is the standard of care you will be held to by the medical board in this state. When it comes to bioidentical hormones, I'm sure you all agree that the bioavailable form is what you want to measure, right? How much is available for the body to use. If you're doing serum testing, you're not getting the bioavailable hormone because it doesn't exist. The science is not here to get bioavailable progesterone by serum. You can get all that by saliva. Saliva is less expensive. And worst of all would be to do urine. Urine, you're getting a metabolite. You're getting a breakdown product. You're not getting the direct measurement of the hormone. It's really important, very important to do urine studies and look at estrogen breakdown and to look at the breakdown of the other hormones. So don't get me wrong, just don't dose off of urine, because if you dose off of urine, you're dosing off of a breakdown product. And how I break it down and you all break it down is really, really different for every patient. So what do the references actually say? So high levels of estrogen increase the patient's risk of developing breast cancer. High levels in relationship to progesterone itself. You do have to give E3. Even if you're using an estradiol patch, then please compound E3 and give it to the patient. It's best just to give biased. It's easier, it's less expensive. But E3 now we know more about. From Menopause 2017, the role of estradiol is expanding. It's helping with menopausal symptoms, bone loss, cancer, hyperlipidemia, vascular disease, and multiple sclerosis. So it's a treatment for MS. When it comes to estrogen receptor sites, we do look at all 3 of them. E2 equally binds to both alpha and beta. The alpha one causes breast cell proliferation. The beta decreases it. E1 we don't replace because it's linked to breast cancer and it preferentially binds to the alpha receptor. E3 preferentially binds to the beta. When it comes to progesterone, there's many wonderful functions in the body, so it helps with anxiety, irritability, insomnia, mood swings, depression, heart racing, bladder problems, gut disturbances, and so much more. This study measured the blood levels, no hormones were given. This was oral of 6,000 women that were premenopausal. This is very startling. This was even in this trial. Women that have a family history like me, they have breast cancer on both sides. Women with the highest levels of progesterone who had regular cycles had an 88% reduction in the risk of developing breast cancer. So in other words, oh, I don't want to cycle because it's inconvenient. People actually say that to all of us in this room. It's not inconvenient. They do need to cycle. 1,000 women, 30-year trial because they were looking at infertility. Women who were deficient in progesterone had a 5.4 times increased risk of developing premenopausal breast cancer, 10 times as likely to die from any cancer. And these studies show that progesterone, the natural form, the bioidentical, the same chemical structure God gave you when you were born does not induce estrogen-stimulated breast cell proliferation. All of these studies showed the same thing. Natural progesterone has been shown to decrease the risk of developing breast cancer in this study of 80,000 women. And this study done by the same researchers, 40% increased risk of developing breast cancer in women who used estrogen with progestin. That was not true if they used natural progesterone. And then the definitive studies. Progestins increase breast cell replication and growth due to the stimulation of estrogen receptors by progestins, and these studies showed progestins increase the risk of breast cancer. Estrogen plus progestins increase breast cancer incidence as well. So does it matter about estrogen and progesterone and their ratio? It does. And on a saliva test, you will get the actual ratio of the hormone because you want to make sure that they're balanced with each other. Does cortisol matter? It does. Remember early on, we talked about stress feeds cancer cells. So abnormal cortisol is associated with all of these diseases, including breast cancer. History of stressful life events are associated with a moderate increased risk of breast cancer. Psychological counseling after the occurrence was very helpful. Melatonin, another hormone. This is also measured by saliva testing. Melatonin has anti-estrogenic activities. It is an immunomodulator, antioxidant, anti-aging, quote unquote, hormone. The spectrum of anti-cancer functions are so great that we use melatonin to now treat stage 4 breast cancer 20 milligrams. And even now in conventional cancer centers, they're using melatonin as adjunct therapy to chemo. I have an addition to that. So what I do is I do the 20 for stage 4, but I do 12 milligrams for stage 3, 6 milligrams for stage 2, and 3 milligrams for stage 1. It's very fascinating. When you go back and you measure melatonin, even if you're using 20 milligrams, it's normal because it's functioning as an immune modulator. And by the way, for COVID, they use 50 milligrams as an immune modulator of melatonin. Melatonin is effective in the prevention and reduction of some of the side effects of chemo. So we also use melatonin as an adjunct to chemotherapy. Still looking at hormones. Insulin. If I had to choose one hormone, this would be it. Even more than estrogen, insulin does regulate the blood sugar. It is a crucial agent that promotes cancer by boosting cell mitoses and migration. So this study of 22,837 postmenopausal women with a fasting blood glucose and insulin levels, they were followed with whether they got breast cancer and whether they died of breast cancer or not. And this is from 2020. Higher levels of insulin resistance in postmenopausal women associated with a higher incidence of breast cancer and a higher all-cause mortality. Perfect blood sugar, if you're under 60, is 70 to 85. If you're above 60, it's 70 to 90. A perfect hemoglobin A1C is 5.4, and a perfect fasting insulin, unless you do what we all do for a living, most people never get their fasting insulin measured. That perfect level is 6. Too high or too low is a problem. And I will share with you, in 47 years of practice, I do a lot of cancer work of many, many kinds of cancer. Many kinds. I've had one patient in all these years who came to me when they were newly diagnosed with any cancer that had a blood sugar under 90. Only one. So please go back and look at what's going on with insulin in the body. Yes, could I get breast cancer? I could. but I'm mitigating my risk factors. Do I have poor methylation? I do. I inherited that on a gene. But nobody in my family is diabetic. My fasting blood sugar at almost 71 is 85. My hemoglobin A1C is 5.4, and my fasting insulin is dead on the money at 6. You can mitigate your risk factors, and you can help your patients mitigate them, no matter what the family history is. And by the way, when it comes to your family history, only 20% of breast cancer is inherited. The other 80% is related to all these other things. Insulin resistance affects the development of breast cancer in 3 ways. It leads to an increase in aromatase. It leads to elevated glucose levels. And thirdly, insulin resistance is associated with elevated leptin, which acts on the brain and increases the risk, because if leptin's not balanced, you have angiogenesis occurring in the body. So insulin dysregulation in this study was putting the body in an environment for estrogen receptors to be open to the idea of getting breast cancer. Oral contraceptive use, I kind of gave you a little hint here. There's both prospective and retrospective studies showing an increase in breast cancer associated with contraceptive pills. It did not matter the type. There is no perfect birth control. I wish I had an answer. Again, I have 5 daughters. There's no perfect answer for birth control. This study showed there was a significant risk factor as well. And this long-term use of oral contraceptives for more than 5 years increased risk of breast cancer from women that are ages 20 to 44. And then this study from 2022 showed that there was a 20 to 30% increased risk in getting breast cancer if you've ever used anything with progestins. Again, it does not matter the fatty history. They looked at it. It didn't matter if they methylated properly or not. It did matter if they were exposed to synthetic hormones. So another study showing the same thing. Of course, you knew I would get to methylation, right? I mean, it does matter. Half of you in here are like me. You are a poor methylator. The other half of you are normal. If you are a normal methylator, if you forget everything else tonight. If you are a normal methylator, or your patient is, please make sure you do not give them methylated vitamins. If you give the patient methylated vitamins and they're a normal methylator, you can give them 22 different symptoms. We have a list. You increase the risk of all cancers, not just breast. So hypomethylation is not a good thing. Obviously, if you're hypermethylating, none of these are good. Hypo is bad, like some of us. Hyper, where you overmethylate the patient, is just as bad. So studies have shown that endogenous estrogens do play a crucial role. There's your pathway of estrogen metabolization into the 2, 4, and 16 hydroxyestrogen. The 2 is the desirous one. The patient needs a little bit of 16 for bone structure. Too much increases the risk of breast cancer. Any 4 is bad. It actually changes DNA. It causes mutations. Of course, I broke down into 4-hydroxy, almost exclusively. But I changed it 37 years ago. Every patient, you can mitigate these risk factors, 100% of them. My homocysteine was high. It doesn't have to be that. It's been normal for 37 years. Your patients can have, with your help, all of these things mitigated. Estrogens are eliminated from the body by different pathways. Phase 1, phase 2 in the liver, and phase 3 in the GI tract. So if the patient on Monday morning comes back and their estrogen is elevated, what are you going to do? Give them a liver detox. You may still need to do a gut health test and fix that as well, because the metabolization of estrogen does matter. All of these studies here show it, including the CYP1B1 pathway. So Here's the references to everything that I just said on the 2-hydroxy pathway. There's the 16. I did not mention that high levels of 16 are associated with obesity, hypothyroidism, pesticide toxicity, omega-6 fatty acid excess, and interestingly, inflammatory cytokines. So 16-hydroxy, too much, causes unscheduled DNA synthesis, and in the mouse model actually made the mammary tissue grow abnormally. So lots of studies looking at 16-hydroxy. Here, 8-fold higher in cancerous mammary cells. So estrogen metabolization, lots of studies on the 2-hydroxy. The 4 is, again, the poor pathway. Studies going back to 1996 have shown that all the way through 2024. And by the way, Premarin breaks down almost exclusively into 4-hydroxyestrogen. So you can raise 2-hydroxy with moderate exercise, cruciferous vegetables, flax, soy, kudzu, broccoli derivatives like indole-3 carbinol, its breakdown product DIM and sulforaphane, anything that supports methylation, omega-3 fatty acids, rosemary, turmeric, weight loss, and a higher protein diet. So you can measure homocysteine, perfect is 6 to 8, too low is bad, too high is bad. You can measure 4, 16, and 2-hydroxyestrogen. You can look at methylation, or you can do an actual methylation test where you get the entire methylation pathway so you can know where your problem is. I have the SNP with methyl-tetrahydrofolate reductase, so I don't need methylated vitamins except for folate, because you can delineate that now. You do not have to guess. It is so cool. And it goes into transsulfuration, and you can see over here is detox, and over here is whether the patient needs glutathione, and they're actually making enough or not. And the amount of glutathione you need does, you make less with age. So all of this you don't have to guess. You can measure in every single patient. It's just such a cool time to be a practitioner, but it's equally a great time to be a patient, because we have so much to offer people. So methylation, poor methylation is a problem. Here, poor methylation is a likely short-term predictor of breast cancer risk. These systems all depend on methylation. Creatine, DNA and RNA synthesis, epigenetic gene regulation, hormone regulation, and the ability to detoxify, energy production, cell membrane repair, lipid metabolism, neurotransmitter production, nitric oxide production, and whether the immune system works or not. So if you haven't measured methylation even in yourself, it's a great thing to look at. These factors support methylation, and then of course homocysteine itself. An increase in homocysteine does increase the risk of breast cancer, along with all of these other kinds of cancer are related to high homocysteine. And first of all, we just thought it was breast and prostate, but the medical literature now, if you go through all of it, each one of these is associated with it. So we talked about measuring homocysteine. So an important aspect of life. And of course, we have to talk about inflammation. Plays a significant role in breast cancer. So the studies show that tumor extrinsic inflammation is caused by infection, autoimmune diseases, obesity, smoking, toxins, excessive alcohol consumption. All of these cause cancer and progression. In contrast, cancer intrinsic activities cause mutations, and this contributes to malignant progression as well. So it's both the extrinsic and the intrinsic inflammation play an equal role in what happens with the patient. Probably if you chose one thing this evening that would help your patient the most would be to decrease inflammation. Number 2 would be to look at insulin if you just had to look at 2. So how do you reduce inflammation in the body? Have a healthy gut, be normal weight, avoid toxins, treat any infections that are there, have hormonal balance, Optimize the blood sugar. Eat an organic diet. Drink only purified water. Do not smoke, and avoid periodontal disease. Kind of short but sweet. But that's what we should be talking about with our patients on Monday morning. Low-dose naltrexone is key. There's a study out of England showing that LDN, 1 milligram a day, helps prevent breast cancer. So I take 1 milligram a day and have for many years. But all my patients with any kind of cancer are on low-dose naltrexone. The most common dose for cancer is here. There are many dosages for LDN. It can be given at any time of day. It no longer has to be given at night. I do serve on the board of the LDN Trust in England. It's an international trust. And we've now discovered, Sebastian Cabot and I have done some research on the tolerance to LDN. Because now we've been giving it for more than 10 years, and some people develop tolerance. So we now recommend that the patient does not take LDN, i.e. they have an LDN holiday, days 1, 2, and 3 of every month. And then they don't tend to develop a tolerance to low-dose naltrexone. So some great studies on LDN and breast cancer. One of the other big causes that happen with inflammation is a lot of it really is not just toxins, it is coming out of the GI tract. I just razzed somebody yesterday, but I was serious. I go, no problem. And I was here in New Jersey. I go, this is like great. Come be my patient. You'll be my patient until I pass away. And they go, why? I go, it's not just bioidentical hormones. You're eating sushi. You'll be my patient forever. If you eat sushi, look at the gut health test. It will not be normal. Again, it's personal choices with people. So you want the gut to be healthy. It is the biggest source of inflammation there is beside toxins, and 70% of the immune system is in the gut. So from 2003, the findings suggest an unrecognized link between dysbiosis and breast cancer, which has a potential diagnostic and therapeutic implications. So when you're looking at breast cancer prevention and treatment with a patient and preventing a reoccurrence, please do a gut health test. Is it more important that she be hormonally balanced in life, or is it more important that she has a healthy gut? They're both equally as important for that patient to be healthy. There is the estrobolome. We now know that there's estrogen going on in the gut. So the role of the intestinal microbe is a modulation of synthetic estrogens. So do not forget that. The modulation of what happens with systemic, estrogens occur in the estrobolome. So it is the aggregate of enteric bacterial genes whose products are capable of metabolizing estrogens. That's what the estrobolome is. So it's all been delineated out in the body. So you can see that high levels, you end up with intestinal reabsorption, i.e. leaky gut. So they get reabsorption of bad things. And then you have low levels where the fecal excretion of the conjugated estrogens occur. So if estrogen metabolism and the gut microbiome access is working properly, she will have a decreased risk. If it is not, then she will have an increased risk in the body. And you can see on that gut health test, beta-glucuronidase activity can be modulated by the diet. So yes, you can give nutrients to help with beta-glucuronidase. You probably all know what some of those are. But you can also fix it by having the person have a healthy diet. So in conclusion, and then we'll take questions, there's many risk factors that are modifiable. I'm sorry we didn't have time to look at the non-modifiable. But the great news is we can help our patients. We can really do something now to help prevent breast cancer. And we can really help it no longer be 1 in 8 women. A study that's coming out next year is supposed to say 1 in 7. Let's go back to 1 in 24 women, what it was 50 years ago. I love this motto of life. Life is not about how to survive the storm, but how to dance in the rain. Thank you very much. So there is my contact information. If you're interested in the personalized medicine certification, it is open to all. We opened it to everybody for all degrees. It is for MDs, DOs, pharmacists, nutritionists, naturopaths, chiropractors. It is for everybody. The goal is we all help people be healthy, right? It takes all of us, so we'd love to have you. It is 3 courses. It is an actual mentorship program, so it is like rotating with myself. And yes, you actually literally can ask questions every day. And yes, someone emailed me on Christmas. And yes, someone emailed me on Hanukkah. Yes, the idea is that you all are able to give all of this. Because I'm going to go needlepoint one of these days, okay? Because that's my other love in life, beside my dog and my husband and my kids. Is I love needle pointing. So my goal is to help all of you prescribe hormones perfectly customized and individualized for every single patient, because all patients deserve that kind of health care, because the science is here to do that. So course number 1 is endocrinology. There are no exams. Both the dean and I feel that exams do what? They tell us you can take a test. You turn in 2 case histories. Each course is 24 hours. And then you look at 2 of 16 webinars. So the first course is taught entirely by myself, all 24 hours. The webinars are done by other professors. Course number 2, we just held in Houston last weekend, because we do rotate it around the country, plus it is available online. So we are the only course tied to a medical school in the world, literally. So it was GI health. We did have Jill Carnahan herself teaching. We taught about infectious disease. It was Richard Horowitz himself teaching Lyme. We looked at autoimmune diseases and dermatology. And Dr. Marguerite Germain will be teaching next time. We give number 2, who's the #1 dermatologist in North America. So she is my dermatologist. I actually go all the way to Charleston for my rosacea because I believe in seeing the best. So that is the goal. There's also a personalized TPE certification now as well, if you want to get certified in that field, because in the next 10 and 20 years, TPE will be the forefront in how we help patients be healthy. Questions? Yes?
Can you go in a little bit into the TPE? This is the first time I've heard of it.
So TPE is therapeutic plasma exchange. So we take out plasma and you put in something else is the definition. Okay, so you put the fluid back in. In this case, they give albumin back, okay? And they also do nutrients, DMSA, they do LDN to decrease the inflammatory component, depending on what studies they're looking at with patients, because they're using it for memory. They may also use stem cells. They may use exosomes. They may use peptides, the ones that are legal in the United States only, okay? So there's a big protocols depending on what disease process you're trying to look at. So to give you an example, 400 patients have been done. We actually had a pharmacist who's one of my friends, and so he wanted to try and reverse his heart disease because he'd had an acute MI. So he's had 4 treatments done, and so we just looked at his vessels yesterday, and the plaquing is significantly decreased. It's very, very fascinating. So we're using it for autoimmune diseases. We had one patient who had 4 autoimmune diseases. She now has 1. Because when you get rid of that toxin load, it helps the patient. I personally sent 3 patients because I couldn't give them hormones. It didn't matter what I did. I could stand on my head. I couldn't give them hormones. They couldn't even take progesterone. They could take nothing. It didn't matter if it was on the skin. It didn't matter if it was a troche. It didn't matter if it was oral. It just didn't matter. We could use a rectal suppository. We tried everything. Toxic load. When we got rid of all 3 women's toxins, then it allowed the hormone receptors to hold on to the hormone. All of them can now take the hormones. We're actually looking at it. We're doing a study with the state of Illinois, looking at the idea of getting women healthier before they conceive. because of the ADD and autism, because all this goes through the breast milk, it goes through the placenta. We look at all of this. So we're trying to see if we can get women to have one treatment of TPE to get rid of it, because they're usually pretty healthy at that age, to see if they can have healthier children. We inadvertently did one patient who she didn't know she was pregnant, and this is what happened. She delivered in Indiana. They actually called everybody in the delivery area and they said, come see this baby. This is the first pink baby we've had in 20 years in this hospital. This is the first baby with normal bilirubin. We haven't seen one in years. So we're looking at it for memory, we're looking at it for a lot of different things. We took 10 people with different stages of cognitive decline. One was a physician who had Alzheimer's. So we don't know what we're going to get. We've only done 10, but it was great because he already had the disease. So he couldn't drive anymore. He couldn't talk like you and I are speaking this evening. He still can't drive, but you know what? After 8 treatments and everything, he got it all, the stem cells, the whole kit and caboodle, and 8 treatments, he actually can now carry on a conversation. So we're looking at it for MS and Parkinson's and all these neurological disorders. So it is going to be where medicine will be the next big thing for medicine for 20 years.
I have a lot of questions, so I'll email you.
So you can email me and more about it, but that's what it's about. Other questions?
I have a question.
Sure.
So I'm a nurse practitioner. I'm fairly new at this. I've been doing it for a couple of years now, and I'm pretty big into developing protocols for a lot of my patients. Right now, anytime someone comes up to me with dense breast, history of endometriosis, fibroids, I know this is on breast primarily, I divert and avoid estrogen at all costs. I was just wondering if you could just touch base on potential blood, saliva, whatever you would recommend in terms of screening, relative contraindications, absolute contraindications in terms of starting perimenopausal, menopausal female on a biostec cream.
Okay, so let's look at everybody.
Okay.
Okay, so this is a broad answer to his question, so I'm answering it in case you didn't hear it in my response. Okay? Let's start with younger women.
Mm-hmm.
When it comes to doing PMS, PCOS, PMDD, etc., you need a bigger picture. Okay? Just doing a test of any kind of test isn't enough because the hormones do this. So what we recommend is a saliva test on day 4, one on day 14, and one on day 21 initially. So then you see, are they ovulating? What is their ratio? All of those things are really important. For the younger women, you need a broader picture. For women who are perimenopausal, they still have fluctuating hormones. Or women who've had an ablation and all these other scenarios that you get. And again, if you're in the program, you actually get all these scenarios, okay? So we usually do a test on day 14 and a test on day 21. Okay, obviously you could do day 4 as well if they're willing to do that. Postmenopausally, we do a 1-day test. Can you start with blood if they're not on hormones? You can. The trouble with doing that is twofold. Blood is more expensive than saliva, so you do want to look at cost to the patient. Okay. Number 2 is later on you're going to use saliva, so then you would be comparing apples to oranges instead of apples to apples. You should be measuring the hormones. In 90 days remeasure, and every 6 months that after. That is the gold standard by your medical board here in New Jersey. It's also the gold standard in New York. So doing it once a year is not adequate per the medical board. Particularly, you have to measure it every 6 months if they're on testosterone, because it is a controlled substance here, and it does require you measuring it every 6 months. Okay? So we do suggest salivary testing for that for all the reasons we talked about tonight. Well, we'll challenge you, though, if you're doing blood, to go back and look. Because remember, nobody here knew how much estradiol she actually made. So I will tell you that if you're using blood now, what's going to happen, you've got my email, okay, is you're going to go home and do one person, even if it's you, and if you're on hormones, it's going to come back high because you've dosed them off of serum, particularly if it's on the skin. So then you can call me, you can email me, and I'm going to say the following. Please do 5 more patients and then call me back. You'll discover you overdosed every single one of them. But remember, part of that is because you didn't know how much she made to start with. So you had no frame of reference. And the bigger issue is that many people don't measure, because many people who are not trained in this field look at it this way. Oh, oral contraceptives, we don't measure you for that, so that's okay, that's just a hormone, so we're going to go over here and just give you hormones. Why would we even need to measure them? Or we can do them by blood. We don't need any special training. But you can see what happens if you're on oral contraceptives. I showed you the studies. Maybe we should be concerned about measuring it and what we give when they're 22 for acne. And then it's just common sense not to use urine because it's a breakdown product when you can directly measure the hormone. Okay? So you can measure the breakdown products and you want to see those, but you don't want to dose off of urine because it's not the direct measurement of the hormone. I don't think anybody in here would dose thyroid off of urine, right? No, you measure TSH and free T3, free T4, reverse T3, and thyroid antibodies. So you want to measure the direct measurement of the hormone itself. But please, come take the course. If you want to take the whole course online, you can. In your age group, that's what people usually do. In my age group, they like to show up in person. So we usually run a hybrid course so that people can pick how they like to learn. Other questions? Yes, ma'am.
I had a question you said about low homocysteine. What kind of disorders cause a low homocysteine?
There actually is a list of low homocysteine disorders, okay? So I can email you that list. It's probably easier because it's quite extensive. And usually, unless you're more than hormonally balanced after 6, you will forget, and there's more than 6. So just email me and I'll send it to you.
Methylated, too much methylation.
It's too much methylation is the number one reason. It's not the only reason, okay? Other questions? Because people are usually startled at that, because a lot of companies do methylated vitamins and they just give them to everybody. Yes?
You were discussing LDN and that there should be holidays and breaks.
Mm-hmm.
How frequently should those breaks be and for how long?
Okay. For low-dose naltrexone, number one, it usually is a lifelong drug, okay? But because it's lifelong, we usually do every single month, no LDN at all, days 1, 2, and 3 of the month, just because it's easier to remember. So 3 days out of the month, okay? And then we're not seeing a tolerance build up, okay?
Do you recommend that most people stay on 1 milligram dose?
From the viewpoint of LDN, if you've got autoimmune diseases, the most common dose is 4.5 milligrams. The next most common is 3. Usually you stay on that dose forever.
But you mentioned 1 milligram.
I take 1 milligram because that's a dose to prevent breast cancer. I don't have any other diseases that I know of that are inflammatory in nature. So I take the 1 milligram to help prevent breast cancer. Yes?
So as the 4.5 was the anti-inflammatory dose from the original studies, if someone's taking 3, they're getting
That's a great question. No one's ever asked me that. They actually studied now micro doses, so like 0.1, okay, et cetera. Baby doses, they're all anti-inflammatory. So every dose is, okay. The studies on autoimmune, almost all of them are 4.5. But remember the studies on hormones. Are you familiar with the studies on autoimmune diseases and hormones? Okay, so if you take rheumatoid arthritis, lupus, scleroderma, and a couple of the big autoimmune diseases, okay, not Hashimoto's, but those major diseases, that psoriasis, things like that. From the rheumatological, immunological literature, they use DHEA, but they use a different dose. Not what we would use for hormonal balance, but they use instead 100 to 200 milligrams a day of DHEA. And interestingly, when you do the saliva test, it's an immune modulator and it's not too high. The same thing with pregnenolone. They actually use big doses, okay, for autoimmune diseases. They use 100 milligrams of pregnenolone instead of starting at 10. Otherwise, we usually start with 10 milligrams and work upwards. Start low and go slow when you dose. The only exception to that is people with seizures. If the patient has a seizure disorder, if you don't give them the dose of pregnenolone if they're deficient, then they can seize. If you give them too much, they can seize. So we usually start at 5 milligrams. Pregnenolone is a blood test. The science is not here to do it by saliva, so I only give pregnenolone PO for that reason. It has to be 50 to maintain memory. I don't take pregnenolone because my level's 55. It was measured in the last 30 days. So don't go by age. If the patient is really, really young for pregnenolone, then usually if they have a pituitary, their low pregnenolone is due to stress. Fix the cause of the problem. If they're over 40, then giving pregnenolone is fine, but measure. Don't give people hormones that they don't need. 50% of women, 40% of women, depending on the study, never need testosterone. I am one of those. If I've gotten to this age without testosterone, I'm never going to lose it. You give me testosterone, you will drive up my blood sugar, you will increase my risk of heart disease. There's now been one death from BHRT, and it has been proven it was from bioidentical hormones. Remember what we all learned the first day in school. Do no harm. Better not to give hormones than to give them incorrectly. Please only give the ones that people need. That's why it's customized. That's why we have compounding. Your compounding pharmacist should be your best friend. He should be. My compounding pharmacists all are. The trouble is I know so many of you, I have a lot of really good friends. So it works out very well. Any final questions?
How about troches, like to use one of them?
Troches allow the hormones to get into the body, as does vaginal allow the hormones to get into the body. The trouble with troches is it makes saliva testing less accurate, and then you have a hard time knowing what to measure because not enough studies have been done on any measurement form with troches. Okay? So it's not that they don't get in the body. Plus, for estrogen, it is oral estrogen. It's almost impossible. I'm not going to say it's totally impossible, but pretty close to impossible not to swallow some of the estrogen. So a troche of estrogen would really not be the road you want to go down.
How about some people with cream? Sometimes they are not intolerant, they're sensitive to it.
If they're sensitive to the cream, her question is about the creams. If they're sensitive to the creams, one of two things is going on. Okay, either they've got toxins going on, or you're giving too much or not balancing, okay, or they're a sensitive person, change the base, okay? So there's many bases that you can put hormones in. So there's bases for sensitive skin, there's gels to drive certain hormones into the body, there's many different bases. That's why John's here, he's here to discuss bases with you too. It's not just dosing. Okay, you have to make sure that the hormones get from the good source, because some sources of hormones are not good. They come from China and places, they can have lead and mercury in them. So I don't speak for every compounding pharmacy in the world. I only speak for people that I know and people that I know where they get the hormones from. It does matter the bases that you put them in. John, do you want to talk about bases for a second?
Sure.
Cool. Thank you.
We have, thank you so much, Dr. Smith. That was amazing. I don't have a microphone. Hopefully my
yes,
mouth
you
is
do.
big enough. I do. Okay. I don't know. Hopefully, can you hear me in the back? Yeah. I'll be all right. Okay. I'll try to talk. Don't give me this. I'll start singing.
That's okay.
Maybe not. That's just in church, I think. Anyway, we have a lot of different bases. So, sometimes the patient's allergic to one base or another. So, there's always, and I use chemicals from, companies that I know where they're getting where I can tell the word source. Typically, companies like PCCA, but the bases are important too. And PCCA has great bases. Typically, with hormones, a lot of times we use bases like Versabase. But for things like testosterone, frequently we use Atribis, because it just seems that there's a lot of studies done, and it seems to pull the drug through the skin better. We get better levels. But there are so many different bases that if somebody is for some reason refractory, it's easy. We're here to make something for your patients from scratch. So it's not an issue for us to change a base. And to give it a shot. And it's always worth a suggestion. Say, hey, how about we change it to this? We're not doing well. I just had this case today, actually. So we're changing the base on another HRT cream. So I'd be happy to talk to you about the different options specifically. But I mean, there's literally a dozen, at least. So we'd be happy to do that, and that's an excellent suggestion. real quick, just closing comments. Can you still hear me here? It was great. We really appreciate the lecture. It was wonderful. And again, Greg, thank you very much for sponsoring this tonight. Remember to check out ZRT and also to check out that course that Doctor is director of. Again, I'm really excited to, I just want to mention 2 things. Please finish up that survey if you can. If you want, on the back, at the back room there's a table, shows some of the different devices, how we dispense things, just in case you're curious how we make the creams and dispense them for some of your patients. Again, we really appreciate this opportunity to collaborate because as practitioners and pharmacists here, we're here to try to do no harm, as Doctor said, but also to make sure we're helping people and improving outcomes. In your packet, please look for, of course, there's that book I mentioned. There's also some educational materials and reference guides, some examples of prescriptions we use in women's health, and some other information about HB pharmacy practitioner support services. So again, thank you so much for participating tonight and for taking that time out of your schedules. We really appreciate you all coming here so we could have a good evening and learn some. Okay, thank you very much. See you. Thank you. I'll talk to you soon. Okay? Thank you.